My name's Chris Lawrence, and I'm the medical director. And it's a great pleasure to see you all here today. We've got a fantastic program for you. We're going to start by handing you over to Valen Keefer, who is our transplant patient advocate at Thermo Fisher Scientific. She's going to say a few words about herself and then introduce each of our speakers in turn. Please enjoy. Thank you.
Hello, everyone. My name is Valen Keefer. I'm grateful to be a patient advocacy consultant for Thermo Fisher Scientific. I'm thrilled to co-moderate today's symposium alongside Dr. Lawrence. It means a lot to have this incredible opportunity to represent our transplant community and bring the patient perspective into today's conversation. As a dual transplant recipient, I've experienced firsthand that transplantation is not a singular event or a cure, but a lifelong journey. One that can start with a diagnosis many years prior to the transplant surgery. I was diagnosed with polycystic kidney disease at 10 years old, which led to me needing a kidney transplant at 19 and a liver transplant at 35. This August, I am so excited to be celebrating my 20-year kidney transplant anniversary and my 4-year liver transplant anniversary. Thank you. I'm still in awe of it every day. My life has been doubled because of organ donation, which just blows my mind. When I received my first transplant, I felt voiceless. I was in the process of switching from pediatric to adult care, and there were no resources or support provided to me. When I found my voice after kidney transplant, I learned to be an advocate for myself and others, which empowered me to be an active participant in my care, to speak up, and led to the last 18 years of my passion to create resources for others that I wish I had. Because receiving the gift of life equals a lifelong journey of living immunosuppressed, which comes with responsibilities, challenges, and ongoing maintenance. I am alive today thanks to science, advancements in modern medicine, and the miracle of transplantation. I hope today to be able to illustrate what the promise of cutting-edge science and the use of novel diagnostics means for those of us striving to take great care of our transplants and who hope to lead long and fulfilling lives. And thanks to the work that Dr. Sharma, Dr. Azzi, and Thermo Fisher Scientific are doing, it is not only improving quality of care, but quality of life for those of us with recipients. I believe Thermo Fisher, including the patient voice today, demonstrates their care and commitment to our amazing community. Because when the trials and triumphs of transplant recipients are understood, I believe it leads to better innovation to improve our quality of life. It means a lot to be here today, and I feel really fortunate to join you in hearing two experts in the use of novel diagnostics in transplantation. After they both speak, we will open the floor to questions. It is now my pleasure to introduce Dr. Rajeev Sharma, who is a transplant surgeon at Wayne Health DMC Harper University Hospital in Detroit, Michigan. He completed his ASTS Transplant Surgery Fellowship at Northwestern University, Chicago, and a Pediatric Transplant Surgery Fellowship at Children's Hospital of Pittsburgh of UPMC in Pittsburgh, Pennsylvania. He has been a tenure-track assistant professor for transplant surgery at University at Buffalo in Buffalo, New York, director of kidney and pancreas transplant programs at Penn State Hershey Medical Center in Hershey, PA, and an associate professor of surgery at University of Nevada, Las Vegas, Nevada. His surgical philosophy is centered on delivering best possible care and achieving best possible outcomes for transplant recipients and their families. Dr. Sharma is well published and has been a recipient of research funding for investigator-initiated studies and clinical trials. His clinical research interest is focused on novel diagnostics and therapeutics for antibody-mediated rejection and kidney transplant. His translational research interest is focused on BK virus-specific cell-mediated immune response and immune surveillance in kidney transplant recipients. Please join me in welcoming Dr. Sharma.
Thank you. you, Valen. Thank you, Chris and One Lambda, for inviting me to give this talk today. The title of my presentation is Clinical Utility of MMDx, Diagnosing Early Antibody-Mediated Rejection. As a disclaimer, the views and opinions expressed in this presentation are mine and do not reflect the official policy or position of One Lambda or any division of Thermo Fisher Scientific. This publication is available on the journal website, and no grant funding was received for the preparation of this publication. So today I'm going to be presenting 2 cases of early antibody-mediated rejection that were diagnosed with the help of donor-derived cell-free DNA and MMDx, and this is the experience that was recently published. I would also like to share our unpublished experience with MMDx, its concordance with pathology, and utility of MMDx and AKI in the post-transplant setting. We are using commercially available MMDx testing as a part of our standard of care for second opinion on all our indication biopsies. So as all of you know, antibody-mediated rejection is the predominant cause for late allograft loss after kidney transplant, and that there is no FDA-approved treatment for this condition as yet. The standard of care treatment based on expert consensus includes glucocorticoids, IVIG, and plasma exchange, with or without rituximab or bortezomib. But the failure rates are very high. So Redfield et al., they published that there was a 55% rate of 2 years graft survival for patients with chronic active ABMR treated with standard of care treatment, while 20% for those who received no treatment. I'm going to concentrate on the clinical phenotypes. So the 2 commonly recognized clinical phenotypes are acute and chronic. Where acute generally occurs early, more responsive to treatment, while chronic occurs late and is not very responsive to treatment. The salient differences between acute and chronic are listed in this table on the right. Then there is the BAMF classification that has been constantly evolving since it was first introduced, with the most recent changes applied in 2019. This is a busy slide just to demonstrate the updates to 2019 BAMF classification. So our understanding of antibody-mediated rejection has been constantly evolving. Once considered an isolated incident occurring after kidney transplant at a point in time, it is now recognized to be a progressive condition that waxes and wanes over time and ultimately may lead to chronic allograft damage and allograft loss. So if it can be diagnosed early, before it has caused significant allograft injury, this could revolutionize the treatment of kidney transplant patients with antibody-mediated rejection, since early treatment will probably result in better long-term allograft survival. MMDx is a central biopsy diagnostic system that uses microarrays to measure mRNA changes with high precision and compare the results to a large reference set using ensembles of up to 100 predefined machine learning-derived algorithms or classifiers. It interprets the rejection and injury-related transcripts in a biopsy. Halloran et al., they used a discovery set, validation set approach of prospectively collected biopsies to document the rejection-associated transcript changes that are either universal, TCMR selective, or ABMR selective. And this table here represents the top 30 mRNA transcripts associated with these archetypes. So coming to the patients, our first patient was a 50-year-old female who received a deceased donor renal transplant for end-stage renal disease secondary to PKD. Her CPRA was 81. She was on hemodialysis for 5 years and was anuric. Donor was a 50-year-old male with a KDPI of 74%. Terminal creatinine was 0.98. Donor had hypertension for over 10 years. No allograft biopsy, so no donor biopsy was available. The pump numbers were marginal. Her past history was significant for cervical cancer, chronic diarrhea, GI bleed, and multiple prior STDs. She was status post-radical hysterectomy with pelvic irradiation. She had a frozen pelvis and calcified iliacs. But the surgery was uneventful. She developed delayed graft function, though. She received induction with basiliximab and methylprednisolone and maintenance with MMF, tacrolimus, and prednisone. Due to chronic diarrhea, she could only tolerate low-dose MMF. She achieved a baseline serum creatinine of 1.1 at about 2.5 months post-op. The baseline donor-derived cell-free DNA at 1 month was 0.41%. The immunosuppression had to be reduced a few times due to bacteremia secondary to recurrent UTIs. The tacrolimus levels were subtherapeutic off and on. As you can see in this slide, the creatinine levels have been pretty steady throughout the course, but the tacrolimus levels were all over the place. There was no donor-specific antibody. At 11 months post-transplant, donor-derived cell-free DNA came back as 1.3%. The serum creatinine was still close to baseline, though. This prompted an indication biopsy due to the elevated donor-derived cell-free DNA. There was mild lymphocytic tubulitis limited to the areas of interstitial fibrosis, and there was a single glomerulus with focal mesangiolisis, which was a finding of undetermined significance. MMDx reported early antibody-mediated rejection. This created a therapeutic dilemma for us since it was the first time that we had encountered such a clinical situation. So we had a long discussion with the patient, and after patient consent, we decided to treat this early antibody-mediated rejection with IVIG. The creatinine levels remained stable throughout the course, and 1 month following treatment completion, the donor-derived cell-free DNA came down to 0.63%. Here is the patient's allograft biopsy. There was no tubulointerstitial inflammation, no endothelitis. Here is the MMDx showing the R4 archetype, which is early antibody-mediated rejection. The second patient was a 30-year-old female who received a deceased donor renal transplant for end-stage renal disease secondary to chronic GN. Her CPRA was 0. She was on peritoneal dialysis for 3 years. She received a perfect donor kidney with a 20-year-old male donor, KDP of 9%, terminal creatinine of 0.9. Her post-transplant course was uncomplicated, and she achieved a baseline serum creatinine of 1 at about 1 month post-transplant. She received induction immunosuppression with basiliximab and methylprednisolone, and maintenance with MMF, tacrolimus, and prednisone. The tacrolimus levels were mostly therapeutic, and there was no DSA. For this patient, the first donor-derived cell-free DNA was only done at 11 months post-transplant, and that was 1.6%. We did not have a baseline for her. Because the patient's serum creatinine was still normal, we decided to wait on it for another month and repeat the donor-derived cell-free DNA. The repeat value came back as 3.9%. These are the serum creatinine and tacrolimus levels over the 1-year course. You can see the creatinine is very steady, very stable. The tacrolimus levels were mostly therapeutic. So this prompted an allograft biopsy. The biopsy demonstrated borderline acute TCMR along with the PTC1. There was occasional mild lymphocytic tubulitis, and the interstitium demonstrated mild lymphoplasmacytic inflammation in the unscarred cortex. It did not meet the BAMF criteria for antibody-mediated rejection. There was no DSA. There was no C4D. MMDx reported early antibody-mediated rejection, but no TCMR. So we treated the patient with methylprednisolone for the TCMR, borderline TCMR on the biopsy, and IVIG for the early antibody-mediated rejection on the MMDx. Serum creatinine remained stable throughout the treatment course. 1 month following treatment completion, the donor-derived cell-free DNA came down to 1.6%. And at last follow-up, the donor-derived cell-free DNA was less than 1. Here is the allograft biopsy showing interstitial inflammation, tubulitis, peritubular capillaritis, no glomerulitis, no endothelitis. Here is the MMDx showing the R4 archetype, which is early antibody-mediated rejection. Now, third case is a patient where I would like to highlight the utility of MMDx in AKI in post-transplant setting. So this was a 63-year-old gentleman with end-stage renal disease secondary to diabetes and hypertension who had been on dialysis for 8 years. He was status post radical prostatectomy with bilateral lymphadenectomy for prostate cancer. He had been anuric for 8 years. His CPRA was 0. He received a deceased donor renal transplant from a 44-year-old donor with a KDPA of 70% and a terminal creatinine of almost 5. The surgery was very difficult due to the bladder reconstruction part, since the bladder, due to the ureteroneocystostomy, since the bladder was extremely small and had a capacity of less than 50 ml. The post-transplant course was complicated by delayed graft function, but the patient achieved baseline creatinine of 1.1 about 3 months post-transplant. Baseline donor-derived cell-free DNA at 1 month post-transplant was 0.3%. At 4 months post-transplant, he developed BK virus nephropathy, for which we switched him from tacrolimus to cyclosporin. MMF dose had to be reduced by 50%. After making these changes, he continued to have low-level BK viremia for about 7 months and only cleared BK virus at about 10 months post-transplant. There was no DSA, but the patient had been on reduced immunosuppression for a long time. The creatinine progressively increased from 1.1 to 2.1 during this time. And the donor-derived cell-free DNA at 10 months, when the creatinine was 2, was still 0.15%. About a month after BK virus clearance, there was a sudden bump in creatinine to 9.4 from 2.1. This was exactly 1 month following BK virus clearance. This was a perfect setup for rejection. The patient had been on low immunosuppression, and we were, pretty confused as what to do with this high creatinine. A biopsy was done. Donor-derived cell-free DNA was done, which is normal. It was still 1.16%. Urine output was good. The ultrasound was normal. Kidney had great flow. This is the trend of the serum creatinine and the cyclosporin and the tacrolimus levels on this patient. You can appreciate that sudden bump in creatinine from 2 to 9.4. The cyclosporin levels were maintained between 150 to 200 because of the BK virus nephropathy. So the allograft biopsy was done, which only showed tubular injury. There was no evidence of rejection. There was no associated glomerular activity. MMDx was also sent on this biopsy, and there was no ABMR, no TCMR, but moderate to severe injury scores. Here is the biopsy showing the tubular injury. And here is the MMDx showing the R1 archetype, which is a non-rejecting archetype. So the diagnosis in this patient was AKI secondary to dehydration. So what had actually happened was he had ultra-small capacity bladder that could only hold urine for about 60 to 90 minutes, even at 1 year post-transplant. The more he drank, the more he urinated, so he started drinking less. And for 3 weeks preceding the event, he was only drinking about 1 liter of fluids every day, and he was still making 2.5 to 3 liters of urine every day. So this led to the AKI. All we did was inpatient IV hydration, and the serum creatinine came back to the baseline of 1.2 within a week, which was better than the 2.1 after BK clearance. So in cases like this, we have found it very useful to have the second opinion of MMDx in addition to the biopsy. Because when there is a perfect setup for rejection to take place and you have a creatinine bump like that, and the biopsy does not show rejection, then it's a difficult decision to make to not treat the patient. MMDx in such situations, at least for us, has proved very helpful as a second opinion. So in conclusion, the histologic assessment of biopsies has its limitations because of the subjective nature of reporting by pathologists and limited reproducibility between observers. While MMDx can assess the T-cell-mediated rejection and antibody-mediated rejection in a reference set of biopsy samples using machine learning-derived classifier algorithms. Molecular interpretation offers as an objective second opinion that adds to local histology findings, thereby increasing clinician confidence with diagnosis and treatment planning. So this is essentially the reason that we have been using MMDx on every single biopsy that we do. Scheduled surveillance with donor-derived cell-free DNA and molecular assessment of biopsy with MMDx have made it possible to diagnose a new phenotype, which is early antibody-mediated rejection. This could potentially revolutionize the kidney transplant landscape by enabling early diagnosis and successful treatment of the commonest cause of late kidney allograft failure, thereby prolonging allograft survival. Thank you for your attention.
Thank you very much, Dr. Sharma. I'm looking forward to our Q&A to discuss your presentation more. It is now my pleasure to introduce Dr. Jamil Azzi, Medical Director, Vascularized Composite Allotransplantation, Associate Director, Kidney and Pancreas Transplantation, Director, Kidney Transplantation Fellowship Program, Associate Professor, Harvard Medical School. Dr. Azzi is an associate physician at the Renal Transplant Division at the Brigham and Women's Hospital, director of the Kidney Transplant Fellowship, and an associate professor of medicine at Harvard Medical School. His research focuses on understanding the immune regulatory arm of the immune system in transplantation, autoimmunity, and cancer with the goal of developing more targeted and safer therapeutic strategies. A major focus currently is regulatory T cells and their activation-induced cell death in addition to engineering cell therapies. Dr. Azzi's laboratory is also exploring multiple genomics and proteomics approaches to develop biomarkers that non-invasively detect rejection in kidney transplant recipients and measure the immune function of immunosuppressed patients. Please join me in welcoming Dr. Azzi.
Thank you. Thank you for joining us today. I don't have patient cases to discuss, unfortunately, but we're hoping with the help of Thermo Fisher, we'll be able to do that next year. So let me see here where my presentation is. Good. So I'll be talking about liquid biopsy in kidney transplant. And I believe, this is the topic that very close to every physician's heart, mostly because we all deal with the frustration of not having really good tools in the clinic to manage our patients. We don't have good tools to measure the immune function of our patients, but also we don't have good tools to measure the health of our transplanted organs. So, almost 70 years now with transplantation, we treat everybody the same. We give them all the same immunosuppressants, and then we wait for complications to happen. We wait for rejection to treat, and we wait for infection and malignancy to realize that we're over-immunosuppressing our patients, and we adjust accordingly. So really, there is a urgent need to develop tools to help us managing our patients. And before I continue, I have some conflict of interest to report regarding the presentation today, intellectual properties with ExosomeDx and Accrue Health and some royalties. I always like to start my talks, especially for the trainee in the audience, talking about some biology, to really, point, that the transplantation is still in its infancy. We were born with billion clones of T cells. Each clone recognizes only one antigen, and the billion clones to cover most of the possible antigen and invaders. And what we do currently, we suppress. In transplant, we have probably more clones and a large number of clones that mobilize against the kidney, but still not the billion clones. And what we do currently is we just suppress everything. And this is what put our patients at risk for infections and malignancies. And really what we do in the clinic is a hand-waving approach to balance between those different kind of complications. And I think for this audience, I don't have to tell you about the limitation of our usual tools we use to monitor our allograft, serum creatinine and serum protein and urine protein, which are basically has low sensitivity and specificity, but they are also late markers of rejection. So, and then, and this really showed the emergent need to develop better tools. And this becomes even more important when we look at the outcome of patients who develop acute rejection within the 6 months. In fact, kidney transplant recipients with early acute rejections, have higher risk of death from cardiovascular disease and cancer and graft failure and chronic allograft nephropathy long term. And so we need this ideal biomarker, and I'm not going to go over the details what an ideal biomarker is, but pointing out that it's very important to have tools with high predictive values. And when we talk about positive predictive values, this is the number of true positive if the test we're running is positive, and this allows us to really treat based on the test. And negative predictive value is the number of true negative if the test is negative. So if the test is negative, this allows us to say that the allograft has no rejection and continue monitoring. But what's important to point out that really the PPV and the MPV are really related to the prevalence of the disease. So when the prevalence is low, like the case of acute rejection, the PPV goes down, but the MPV goes up. So it's very hard to really develop biomarkers with both high PPVs and MPVs. And in my opinion, what we need really is a battery of biomarkers to help us manage our patient, some with high PPVs and some with high NPVs. So, and then, really we owe the advance in the field of biomarker to our understanding of biology. So the T cells get activated in the secondary lymphoid organs and home to the allograft where they cause the injury. So really we can look at this process either in the periphery or in the allograft itself, or in the case of kidney transplant, which is a unique scenario, we can look in the urine. And people may argue that kidney biopsy is a gold standard, but is it really a gold standard? And we just heard about the limitation from sampling error to really inter-observer variability. So, and this is where what the MMDx is trying to solve. And then but the blood and the urine obviously are a very attractive platform to develop biomarkers. But it's really what's happening in the periphery does really reflect what's happening in the microenvironment of the allograft. However, when we talk about urine, the urine in the kidney transplants is directly derived from the allograft and will carry a very concentrated signature from the allograft. And this is one way to look at the explored biomarkers in the field currently. And most of those are in the clinic, and I will talk about some of them. We can, in the pre-transplant setting, we have the donor-specific antibody that I'm sure all of us use, but they work as a risk susceptibility biomarkers, which is great. It gives us an idea about the risk of our patients for developing rejection going on, and can be used pre-transplant. But also we have a biomarker that now used post-transplant, and we are all using them. And an example is the cell-free DNA, and the biology behind that is nice. That all cells, including donor kidneys, at baseline will continuously leak fragmented DNA into the recipient blood. However, in the cases of injury, you can expect that this leaked DNA to increase. So the ratio of donor to recipient DNA will obviously go up. And in a steady state, this is approximately constitute less than 1%. The recipient, the donor DNA from the recipient is less than 1%. And the good thing about that it's the short half-life of the cell-free DNA is about 30 minutes. So theoretically, it would trend down quickly after the etiology is corrected. But clearly, as you can see, this is a marker of injury. This is not specifically a marker of rejection. So, and this is the DART study that really launched the cell-free DNA, and all of us use it based on this study that showed that, in 107 biopsies that with cell-free DNA measured in the blood, there was a correlation with rejection for a cutoff when it was 1%. And the MPV was 84% and the PPV was 61%, and based on that, a lot of clinicians now use the cell-free DNA. But you always have to remember that there are the 1A patients with cellular rejection 1A were excluded from this study, and if they were used, probably the performance would have been lower. And those are patients important to diagnose if we believe that those are early rejection process. And how about the urine? I cannot but mention this pioneering work by Sutan Tiran group, really that launched the work in urinary biomarkers and inspired a lot of us to work on this. And this is the mRNA in the urinary cells. And the rationale of measuring mRNA in the urine is, a cell palette that we can isolate in the urine. They come directly from the allograft. And during rejection process, some of those cells are cytotoxic cells that will end up in the urine, and we can measure transcripts related to rejection in the cell palette and correlate that with rejection. And this is exactly what Sutan Tiran group did, and this is one of the first studies that they published, and they looked at coenzyme B and perforin and had a good association with rejection with a good performance. And this was followed by multiple studies, including this large multicentral trial. This is the CTOT-04, and then that showed, they looked at 9 transcripts that are known to be associated with rejection in a very targeted approach, and they were able to identify 3 that correlated with rejection. But the question is always, why this did not move quickly, to the clinic. And the reason is, at least in my opinion, is the difficulty of maintaining this RNA intact in the urine. And the cell palette, the cells that they end up in the urine, those are cells that are dying, and most likely this will lead to decay of the RNA very quickly and makes it harder to translate that to a clinical test. And really, the limitation of the urine cell palette, our convincing, our thought that the urine will carry a very concentrated signature from the allograft itself, made us focus on the urine as a way to develop biomarkers. And and this has also ignited our interest in extracellular vesicles as potential for developing this test. And so what are those EVs? So EVs are released as part of the normal physiology of cells. All cells will bud off from their membrane, vesicles, that will carry protein from the cell, RNA from the cell, and even DNA. And those vesicles work as cargo, and it's been shown, and this is extensive science going, that those vesicles can play a major role in intercellular communication by going and fusing in target cells and exchanging informations. And personally, I was interested in how regulatory T cells use EVs to suppress the microenvironment. But then, and they can also be broadly divided into 2 categories. We talked, those are the ectosomes and the exosomes. So the ectosomes are vesicles that pinch off the surface, but the exosome, they come from from endosomal origin, and their size is usually significantly smaller than the microvesicles. So, but those EVs, as I told you, carry all these informations from protein to RNA to microRNA to DNA from the parent cells, and they will end up in biologic fluids, such as the urine, the blood, and the CSF. So imagine what a great source of biomarkers to report on the status of the cells, where they come from. And basically, this group used a fancy reporter to image exosomes released from cells. Okay, this video is not working, so you have to take my word for that. And then this reporter shows the active release of EVs from those cells, and it's been shown that more than 20,000 EVs are released from cells per day, from each cell. But when you compare that to cell-free DNA released from cells, it's only released when the cells die. Similarly to cell pallet, those are dying cells ending up in the urine. So the exosome, however, is an active process and can continuously inform on the cell status and can be a perfect platform for molecular signature. And now, while we're doing a bulk analysis of those EVs, you can imagine a future where the technology will go in isolating EVs related to each type of cell and interrogating those EVs separately and having a perfect platform for the liquid biopsy development. This is one of the first experiments we did. And again, I was interested in how T cells release EVs. So the EVs are too small to be able to characterize by flow cytometry. So we basically used to isolate them from the cell culture and then bind them to beads and then add antibodies to this. I know why this is. But anyway, and then we were able to characterize those EVs. And this is the first experiment we did where we looked at EVs coming from T cells versus EVs coming from no T cells. And we found that CD3, which is the hallmark protein of T cells, exists in those EVs coming from T cells, but not from non-T cells. So, obviously, being a clinician and dealing with all this frustration of not having really good tools to diagnose rejection, we asked the simple question: if all cells in the kidney release EVs and end up in the urine, and now if you have infiltrating immune cells in the kidney, the EVs coming from immune cells will also end up in the urine. And if you have technology to separate between those coming from immune cells versus non-immune cells, we can have a snapshot of what's going on in the kidney. And this is exactly what we did. And okay, so also you have to take my word for that. And here I was showing you in fact an EV from the first patient we recruited to the study. A patient of mine developed cellular rejection. We isolated the EVs, and we were able to see enriched CD3 EV derived from T cells. And with electron microscopy, we were able to find those CD3 positive EVs in the urine. And this, gave us the proof of concept that this is a good hypothesis to carry on. And so, in that regard, what we did, we started, we took T cells, we isolated EVs from the supernatant using ultracentrifugation and a process that I'm not go over now. And we found that those EVs coming from T cells have not only CD3, but other markers of T cells. And we used flow cytometry, we used ELISA, but also we used another technology that was developed by a colleague of mine and a collaborator, Hako Lee, in Mass General. And with this, what we did here is using a microchips that we loaded with urinary EVs, and we can, and then if there is if those EVs express a specific protein, it will be retained, and through an electrochemical reaction, it can it can this IKEA can report on the signal and use that as a point of care device. And this device is smaller than a mouse, basically. And the proof of concept came that looking at all these different proteins, consistently CD3 was the highest expressed in cellular rejection. And with that, we continued the study and tried to correlate CD3 expression in the rejection with those CD3 positive EVs. But the question then now, we decided that yes, this is good, but this has more potential. So and then with all these constituents of the EVs in the urine, we can develop a high throughput analysis. And this is what we did. We isolated EVs and we started doing proteomics and genomics. And at that point, I met Johan Skog, who was a postdoc at MGH, who really one of the first people started working on EVs, then moved to a company called MMDx and to really develop a clinical platform for EV isolation and development of biomarkers with EV in cancer. And I teamed up with Johan, and we partnered on this project going forward, mostly to use the clinical platform that will allow us to, whatever we find in discovery, we have the highest chance to translate to the clinic. And this is our publication in JASN recently. And in that, we enrolled 175 kidney transplant patients at the time of a clinically indicated renal biopsy from 3 renal centers. We had 219 urine samples, and we included matched urine with the biopsy, obviously, and we included TCMR 1A, 1B, and 2, but also acute active and chronic active ABMR, and we excluded that borderline and BK virus nephropathy. And this is the patient characteristics and showing that there was some difference in the GFR and the rate of previous rejection, but no difference in the other characteristics. And what we did, the process here, it was done in a clinical lab to isolate the exosomal RNA using technology developed by MMDx for isolation. And then with that, running an open array analysis using 600 genes. And after that, it included like 21 endogenous control. And with that, we, in a second phase, we narrowed down this to 112 genes that we thought the most promising. And then we did this, analysis, but we didn't do a classical approach of dividing the sample into 2/3 training and 1/3 validation, but we used this cross-validation technique to generate the rejection probabilities. And this is based on our discussion with biostatistician that this approach gives better indication of how well this model will perform on unseen data in the future. And this is the signature we identified that can separate rejection from no rejection. And then also because this is a molecular signature, and then you can imagine that it allows you to, with higher number of patients with enough depth to be able to discriminate between different diseases. And in that case, we were able to differentiate between ABMR and TCMR. And this is, so the relative quantities of each target gene goes into an algorithm to generate a single score from 0 to 1. And this is the waterfall plot, and you can see the red bars are the scores from samples that have clinical rejection, and the green are from a sample with no rejection. And we then derived this cutoff for gene signatures. And the same we did to separate between ABMR and ACMR. And here, if the red bars is for patients with AMR, and the green bars are patients from TCMR. So patients below the cutoff are most likely to be TCMR. And this is the ROC analysis that's very promising with an AUC close to 0.9. And also this is the signature that discriminate rejection from cellular rejection from antibody-mediated rejection. And this is to show, a high negative predictive value, but it kept a decent positive predictive value. And the way we envision using this signature is first we run the first signature to differentiate between rejection and no rejection. And if it's below the cutoff, this means we can rule out rejection with high certainty, and we continue to monitoring patient. But if it's above, then we can run the second signature to give us an idea if this is cellular rejection or antibody-mediated rejection. But this is what I'm excited about. And if we take the urine from the -80, we thaw it, and then we start isolating RNAs, and then looking at and measure those mRNA, the results are comparable over time at 4 degrees. And this tells you how stable those RNAs are in the urine. And this is different because the EVs are shielding the RNA from the RNAs. And I think that's the power of this technology and this platform. So now you can envision a test where the urine is collected at home and shipped to the lab for measurement. And exactly this is what we do. This is you can see this is from in our lab. This is the ice packs in this kit that we send to patient. We ask to put in the fridge for a few hours, then put it back in the box with the urine cup, and UPS can pick up the urine and brings it to our lab for analysis. And so we are now in the midst of finalizing our second paper. Unfortunately, I didn't have time to present the data. So now the signature is transferred to a CLIA lab on RT-PCR, and the urine test is called ExoTrue. And the signature remains strong with very high NPV. We have an external validation with 400 urine samples. Half of them came from protocol biopsies. So the performance for for-cause rejection is the same as for subclinical rejection. And this is something, again, we're excited about. And I cannot help but show you this. So we do basic science work on mice. And I didn't know what CD74 is, but CD74 was the highest expressed gene in our signature from EVs. So we generated mice with CRISPR, and then if you transplant a heart from a white mice into a black mouse, they reject in 7 days. Very stringent model. But if you transplant heart from a Biopsy into the knockout, basically no rejection. And what is telling me that the signature we found is biologically significant. And then to me was a reassurance that the platform is also working well. So many challenges remain for biomarker discovery, but in my opinion, things are looking very promising with many players in the field and many biomarkers moving for clinical use. And finally, I'll have some acknowledgement. The lab, Jean-Pierre started this work, and then Rania continued, but really everybody in the lab helped, and they are on schedule to collect sample from patients. But this work really is the group at MMDx that I cannot but say great things about them. Johan Skog, James Hurley, Vashist, and Brian, but also many collaborators from MGH, from Yale, and generous collaboration with Fadi Lakis and Camilla to validate our finding in an external validation group. And obviously all my colleagues at the TRC who've been extremely helpful and supportive. And thank you.
Thank you so much, Dr. Azzi. I'm sitting there and thinking to myself, how does this transition into being a patient? And something really stuck out to me, Dr. Azzi, is you said to have better tools because it's like you're waiting for something to go wrong. And that's so interesting because it made me feel like as a patient, you get a transplant and you almost have this fear of waiting if something's going to go wrong. So how amazing if we could have tools so that we don't have to live in that fear. So thank you for that heartfelt sentiment. Also just had these thoughts from a patient perspective that we want all of the information we can get to make the most educated decisions. If we had just added confidence into the results, like I get monthly lab work done, I've done it for almost 20 years, and there is always a little like, this ping whenever the results come through in the email. I'm like, okay, I'm gonna open it up, I'm instantly gonna look at creatinine and ALT, and I'm just gonna hope for good numbers, and then no, I'm just gonna go for another month and enjoy the next month until labs again. It's like you always just have that connection to your numbers and knowing that they basically dictate your future. And the more certainty we can have, just the more confidence and comfort I think it would give us as patients on this journey. Like with biopsies, if we can have more certainty that we wouldn't have to think in our minds that maybe we'd need another repeat biopsy to look into it more would be huge. I had my liver transplant 4 years ago, and about 8 months into it, my numbers spiked, and immediate reaction is fear, and they told me I needed a biopsy. The anxiety I had around that was almost just, I didn't understand why, and sure. You think a biopsy itself isn't a big deal, but I was so nervous that day of thinking that a needle was going to go into my liver, and my husband said a sentiment that stuck with me. He said, it's not what you're having done today, but it's the trauma you've endured leading up to this point that is making today what it is and these emotions that you're having. So if we could just have more certainty and confidence and comfort in the results and not have to go through additional testing, it would really impact our lives positively. And I also think that they put me on a high course, this high dosage of prednisone for a while, just because they thought I might have had rejection. I got the biopsy results, it wasn't rejection, which meant I took all those immunosuppressants that technically I didn't need. And we know that the more immunosuppressants that we take, the more we're at higher risk for infection and all of those issues as well. And the thought of being able to do a urine test at home is mind-blowing to me. I love it because I, during COVID, participated in an at-home research study. Took my blood at home, sent it back in. It was so easy and it was exciting because I felt really active in my care, like I was doing something. So to think if I could do that at home would be amazing. And I think it would be neat to think if that's just part of your care and you could have those results and it would be something a lot easier. Like a sentiment I had to learn to love is following your trend of numbers, because I'll get results and the creatinine goes up and you're instantly like, oh, is something wrong? And they're like, no, we'll wait till next month, follow the trend. I was like, okay, I've had to learn that, learn to love that statement. But just listening to this, sitting here, thinking of the young version of me that didn't have education or hope or a community, and just to listen to what we've learned today and the hope for the future. And I'm just so appreciative for all of you and the work that you're doing to make a difference in my life and my future and all of us in the community. It's just an honor to just be here today with all of you. Thank you.
Okay, thanks very much for those wonderful talks. Can I open the floor to any questions? I think we've got some roving microphones. There's a question over there.
Thank you very much. I enjoyed your talks, specifically about the looking for the mRNA in urine. Are these still functional
Thank you for this question. Great question. So obviously, this platform carry those EVs. We didn't do the experiment where we isolated those mRNA and see if they can, translate. But what I can say that those microvesicles and EVs carry a lot of proteins. And in fact, we have a protein work and with a protein signature that we're working on. But the signature from mRNA was very stable and was very strong, so we could not ignore it. But I agree that there are potentials of doing proteomic on those EVs, and we're pursuing that.
I really enjoyed the talks. My question is for Dr. Sharma. You had presented first 2 cases where you said the MMDx had early ABMR, but there were no DSA in these patients.
No, there was no DSA.
So did they develop it subsequently?
No, they did not. And we just followed with the donor-derived cell-free DNA for response to treatment. We treated them with IVIG, which was the most benign treatment, but we were not going to leave them with a diagnosis of early antibody-mediated rejection and no treatment. Again, it's
I'm having a hard time conceptualizing that we have antibody-mediated rejection, but no antibodies. So whether it's...
right. How many times do we see, antibody-mediated rejection without DSA? I would say, in my experience, at least 15 to 20% of the times, in my experience. And I would say I've treated about 12 patients in the last 1 year, and about 2 of them had no DSA, but the biopsy had full-blown, ABMR.
Were there other antibodies like AT1R?
No, we're not testing. We don't have the ability to test a DMC for AT1R and MICA, MICB. So we did not test for any of those.
Thank you.
Absolutely.
Thank you. If I can just add to that, that we know that MMDx picks up more antibody-mediated rejection than traditional histopathology, and we think there are 3 possible reasons for this. One is that when we look at the antibody profiles of those patients, some of them have got clear epitope patterns that are below the MFI cutoff. So that's a proportion of them is due to not calling the DSA that is there. We think that a proportion of them may have non-HLA antibodies, and at 1 lambda we're going to test the sera from the trifecta study patients to identify what proportion of patients those are and what antibodies those might be. And the third reason is that we think that some of it may be due to NK cell and missing self. Those are the 3 reasons why we see DSA negative ABMR, we think. It's a fantastic question. Thank you for those questions. Any other questions from the floor? So, but whilst I have a captive audience, I'd just like to let you know that tomorrow we have an extremely busy day in the abstract halls. At 3:30 in the afternoon in the Heinz Ballroom A, we have our collaborators from TSI, the inventors of MMDx, talking about the correlation between MMDx histology and clinical variables, and also the molecular features of late T-cell mediated rejection. At 5:30, presentation 337 in room 210, we have a presentation on the molecular features of chronic lung allograft disease, which has parallels with molecular features in kidney biopsies at risk of progression. And finally, at 7 p.m. in Heinz Halls C and D, our colleagues from Alaris are presenting on their urinary metabolomic tests, and I encourage you to go and listen to that. It will be really very exciting. And finally, I'd just like to thank all of you for attending and thank our presenters today. Thanks very much.